your buddy to give everything. What about MRI? You don't want them to miss your MRI. See if you can get nursing transport. See if the charge nurse can take them. You know, you don't want to just bump them because an admission's coming. So, you know, take 10 minutes, go to the bathroom. I'm serious. If you have a patient coming in that's in this zone, you're going to be busy. Have a snack. Maybe you don't have time to eat lunch, but grab something to eat. Go to the bathroom, set up your other patient. Do your note, do your education, like do as much charting as you can so that you can leave happy, charted on time, and love your job. So the more you can pre-plan to set up your day, then one, you'll have more time to dedicate to your other patient, and you already know that your other patient's taken care of.
So the plan for this patient is we're going to admit them for monitoring, and they're going to go to IR in the morning. They're going to get their ACOM, which is, by the way, ACOM is probably the most common aneurysm spot. It's, I think, 40%. So we're going to do our first neuro check. They come up, actually down the ED. We went down the ED. Mm-hmm. And lo and behold, the exam was exactly what the ED nurse told you.
So,
shh, don't faint. Okay.
So, yeah, you go down to meet your patient, and thankfully the exam, also, you know, I check in with MCCS a lot. It's also, you know, even when I wasn't charged all the time. But, like, as a nurse, like, someone's seen your patient, like, have charge ask them or ask them, like, hey, what exam did you get? Like, if there's no note, if there's nothing, like, they'll be happy to give you a tiny little rundown of what they saw when you go downstairs. So when you get downstairs, you know, ED nurses are not neuroscience ICU nurses, and we are not ED nurses. So, like, we're going to do things differently.
That's
so
true.
Their neuro exam is not going to be our neuro exam, and that's fine. But MCCS neuro exam should be our neuro exam. So if you compare your first meeting to their first meeting, you should know where you stand.
Okay. So they come up about an hour later. The patient's now more lethargic. GCS is now 9. The left upper is now only a flicker to pain. So the next question is, now what are we going to do?
What are we going to do? Yep, a plan to go to CT. Perfect. That's true. What else are you going to do? I heard it. Someone said it. Call MCCS. Yes, this is only a drop by one, but
look at that. The first 2 answers. People are so good.
If your GCS is 9, what do you think you're going to do in the near future? Intubate. Perfect. So that, you know, we can use all these tools we have to plan what's going to go on. If you know you went from a 10 to a 9, I don't care what the image really looked like. If your patient's having a change in that direction, you already know, hey, I should call respiratory because they're not already intubated. Have them come see your patient. They're going to know the same thing. They can already go get event ready. They can also start getting stuff ready.
That's right.
To be available and be fast. So, what medications do you think this patient's going to need? Someone, Dr. Ramesh is in the room. It's an emergency. Let's go. What does she want?
Thank you.
What drugs? What? Okay, so your patient only has peripherals. What do you say? There you go. So, sometimes when people are in a hurry, when we're all in a hurry, they'll order something because they don't know what type of access your patient has. They're not thinking about it in that manner. They know they want to give a hypertonic, but they forget the patient only has peripheral IVs. So that's when you have to suggest, I only have peripherals in place. Would you like someone to go grab the IO kit? Or would you like to spend the time to put a line in? That's for them to decide, but it's for us to bring up because they'll order the 23%, they'll want it done yesterday, and we have to say, well, we can't give that anywhere yet.
Which hypertonics can we put through a peripheral IV?
Perfect.
Bicarb. Dr. Janani likes bicarb. I'm sure all of us have pushed it. Mannitol bicarb. They're the ones that we can do peripherally, and then if you have central access.
So offer these. Like,
yeah.
We are all very smart, wonderful nurses. So if they want something and it's going to take a minute, be like, in the meantime, I could grab you bicarb. I can grab you mannitol. We have all these things available in our beautiful Brainco box right here. Do you want me to give this in the meantime? You can absolutely bring that up.
And also remember, pass on to your buddy. I've had as charge, I've been asked whether or not mannitol can go peripherally, and it can. So if you know, and you can help people remember that they don't have to have central access for that. Do we need intubate? We talked about that. Should we go to the procedure
So
sooner?
originally this patient was supposed to go IR in the morning because it's a Sunday. And everyone's golfing. So, you know, again, plan on going to CT, coming back, doing a bunch of stuff, and then plan on probably going to a procedure.
Do we need an EVD?
And does everyone think we need the EVD? Yes.
Yay! Okay, excellent. So now we're going to just quickly talk about phase 2. So we had a lot of drama here in the first 24 hours. Now our patients went to IR or OR, they're clipped, or they went to 4-vessel and they're 4-vessel negative. So what does that mean to be 4-vessel negative? They couldn't find anything. Why do you think they couldn't find anything? Right, the blood actually clots off the whatever is ruptured. It makes its own little patch. So anyway, they went, we figured out, we've done everything we can intervention-wise, so now they're just going to come to the neuro ICU and we're going to take care of, well, they're going to stay with us. They've always been with us, but you understand what I'm saying. And I call this the rest period. I've actually had patients where the doctors have switched them to Q2 checks, trying to get them to get more rest because they know that eventually it's not going to be that way, okay? So we have the goal is basically the same. Typically we have an EVD, CPP goal, or a MAP goal. We're watching these patients. If they don't have an EVD, they might need an EVD. Here's an example of some progressive drowsiness. They get incontinent. They weren't totally stolen image from the internet. Watching for rebleed. Typically in the first chances of the first 2 days, they're all going to be in pain, right? So have an appropriate pain regimen. What would be an appropriate pain regimen for a subarachnoid?
Okay, that is an issue. That's fine. Yeah.
And then pushes for severe.
And you can advocate for the patient.
But if you're pushing fentanyl every hour, you probably need a better plan. Okay.
Not every drug works for every patient. So
TCDs. And hyponatremia. And the only reason I bring this up is typically hyponatremia develops for these subarachnoid patients. So you might have a patient who is on fluid restrictions. They can only have Powerade. It all is part of a side effect of having the blood in your brain, where their sodium will be dropped. Sometimes they're not on an increased sodium goal. They're just on 3% to keep their sodium normal. Okay? So I love this picture. You know me, I'm all about pictures. This is a ruptured aneurysm, and it's irritating this artery. And this is vasospasm. The artery is smaller. So the reason I bring this up is to understand what Dave does with TCDs. And transcranial Doppler, the point of transcranial Doppler is to actually look at the flow of every artery. If your diameter of your artery gets smaller, that means the flow will be faster. So this velocity would be slower. This would be faster. So that's how he's able to see if someone's in severe vasospasm. He's actually looking at the trend. But I just love this picture because it gives you an idea of what it happens. They believe it's the direct result of the just like this picture shows, okay? It tends to not happen to people that have paramesencephalic, which is kind of like a vein leaking. It doesn't happen as often with trauma. But an aneurysm, that the fact that your blood pressure's high and it's like a machine gun going off in your brain, those are the people that tend to have problems with vasospasms. Oh, yeah, this is a good question. Why do we keep our subarachnoid patients for 14 days? Correct. Because the DCI can go as far as 12 days. Most often occurs at around 7 days. And the highest risk are those that are Fisher grade 3, and as you can see on the grade there, and also young females. I know we had one recently in 5 that was in vasospasm, and she was just complaining of headache and being very needy, but she was really the highest risk. And she probably was day 7 when she ended up going back to 4-vessel. I don't know. Statistics.
one of the other joys of being a woman.
Where have you been? So one of the things else to remember is that the focal spasm is usually preceded by a decline in mental status. I know, and my experience has been like we had a patient that was talking and then stopped talking, or was speaking in English and then went back to their original language. They couldn't speak English anymore. And family noticed that they were just not the same. Okay, so here we are now in phase 3. We're watching for DCI, Delayed Cerebral, and we're at risk for vasospasm.
And this is a big window. I mean, this is how the phases go. Like, we didn't make these up. Like, there are phases for subarachnoid hemorrhage, but like day 4 to to day 21 is a large span of time, and your risk for DCI is usually between, depending who you talk to, Danescu, Alto, whoever, 4 to 9, right? So there's a range there, and then after that, that care does need to remain because it is possible all the way up through at least 12 days, but a lot of different things are going to be happening with the patient throughout this 4 to 21 day window. So it's like a very long phase of care with a lot of ups and downs.
So just talking about it quickly from your experience, what do you think is kind of the first thing to happen? If we see someone, if we have some evidence that this, no, actually, I'm switching slides. This is the slide where we talk about what you're looking for. Yeah. Okay, so what are you doing? You are watching for new focal deficits. Let's talk about what you'd be watching for. What are some of the deficits that could be new? Drift, weakness, other things.
Aphasia, apraxia, pupil changes. So again, a decline in the GCS. Anytime you have a GCS decline over 2, please call MCCS. Always, always, always. That's a good thing. And then this area gets hard because sometimes your patients, especially if they're, between a Hunt test 2 or 4, a lot of them are confused or can be a little lethargic in the 3 to 4 range, and their exam's hard to follow. We call it waxing and waning, and you'll call MCCS and you'll be like, or your charge nurse or your buddy, you'll be like, like last hour, when I walked into the room, their eyes opened, and they kind of tracked me and went back to sleep, and this time I had to be like, hey friend, wake up, and just a little worried. And then if you call, they're going to be like, just watch it. But it's like, what does that mean? That probably means something different to everyone in every situation. So whatever your nursing gut tells you to do, whatever alarm that is, go with that. Watch it doesn't mean you have to wait an hour. So that, it's a very hard situation for everyone. So these people have better exams sometimes and not better exams other times, but it's our job to catch it. That's why we're doing a neuro exam every hour.
Has anyone ever experienced the DCI? Someone
Has anyone seen DCI happen before your face?
So tell me what happened. What did you see?
Share an experience.
There was a young African American girl in the 11 once who had a very long, very torturous first semester. Her first sign was always an increase on her. Always. As soon as you notice that,
So how often do you think you found yourself assessing?
She probably had about 4 of those episodes before she left the ICU. And the order was for early, but personally, I kind of spent a lot of time in that room with her.
Right.
Whenever it wasn't in my other room, I was there with her, just making sure she was still talking to me.
So that's perfect. You saw something, and then I thought your nursing gut or whatever told you an hour's not going to cut it. I need to at least maybe not be asking her to hold her arms up, but being in her presence, staying with her, because the moment there is a change, she needs the fluid. And if that happened you did an exam at 12, and that actually happens at 12:05, you don't catch it till 1, that's a long period of time. So, if you ever need help, or if you're ever not sure, or if you're ever, grab a buddy, grab a friend, do it together, talk it out, and if you really need someone to come to your bedside, the charge nurse or whoever will help someone get someone to your bedside. Don't feel like you shouldn't speak up because they're like, oh yeah, we know they do that. They wax and wait. Sometimes if that doesn't feel like an acceptable answer, you don't have to go with it.
And I think also sometimes that shift change, something happened and they said it was okay, and now this is the new exam. I know that's actually happened sometimes too. So we just have to make sure that we're we're preserving brain function. This is where we're talking about nursing vigilance. You can also ask MCCS, where do you think the likely place will be that they might have a deficit? I know that we had a patient once where they're like, usually it'll be the leg. The right leg might start becoming weak. And so it can give you an idea of what part of your exam is the most important. Because, going in and doing a full neuro exam every hour on a patient that's in a DCI window, they're never going to get any rest, right? So we have to we have to make sense, right? So let's see. And another one I think that's a good example is if you are giving somebody, they have a headache, and you're giving them meds, you give them everything, and they're still, it didn't get better. That's also a sign of DCI. a vasospasm. Because if they're no longer responding to the pain management that was, adequate, 10 of oxy plus 50 of fentanyl or whatever it is, and then they're still having a lot of pain, and that's what happened to the girl in 5. We thought she was just complaining. She thought she was being histrionic. She was in severe vasospasm. So she went to 4 vessel first thing the next morning. She was a lot better.
With this theory,
Also,
I'm sorry.
No, go ahead.
I know we're talking about subarach, but wouldn't this watching for DCI also apply to certain ischemic patients like
Absolutely.
moya?
Yes.
Because they're so variable and they're constantly stroking.
Absolutely.
I know Kristen and I had a guy in 10, a Hispanic man, and I mean from the morning he would go from being completely mobile on the left to completely flaccid and back to completely
Yes.
mobile.
Absolutely.
So those are
Another thing with the pain medicine, I just want to remind people to be mindful of the way we are bringing things up. If you're like making a phone call because you're worried that your patient's having a change or that they might be in DCI, and you're like, I gave them, fentanyl, oxy, whatever, they just, not on purpose, but might think you're thinking you just want more pain medicine. Like, verbally say, their pain has been controlled. I've never had to give them this much pain medicine before. I don't think that they need more pain medicine. I think they need you to come to the bed and do a neuro exam, and just say that. Be like, I actually don't want you to order me anything. I actually want you to come see the patient. You can ask them to do that, and they'll be happy to come see. Because I think initially they're just like, okay, well, don't give them anything else right now, or give them 25 more fentanyl, reassess. Like, if you feel like you went from covering them every couple of hours to you gave them a gamut and they're still in pain, then make sure you get someone to your bedside.
Mm-hmm. So we're assuming now we have some vasospasm, and TCDs are showing it, the pain or whatever. They're having a new focal deficit. What is one of the first things that we do for people? Well, typically we do give a bolus, which is funny that we didn't actually add that. But what is one of the treatment plans that change for people who are in vasospasm? Correct. The MAP is increased. The CPP is increased. And we're now in the window of permissive hypertension. And I have this picture here because I think of vasospasm as a kinked hose. So, everything for me is an analogy. So I explain everything to families.
I was like, how did you even find a picture of that? Yes.
So I just want to say double because they do.
Which one?
you should see.
Oh, I don't actually think we said that, but
The ones that you said they didn't find anything.
oh, I was
I
just
think she was just talking about something else.
in general.
I just want to say the
Yeah,
fact
absolutely.
that definitely have to be
Correct. Yeah, and that's true. If it's an unsecured AVM, unsecured aneurysm, they're a little more cautious about their CPP. Correct.
And then sometimes we end up with those weird goals, 75 to 110 or whatever, and like that's kind of when they're splitting the difference. We were pretty sure something's there, but they couldn't find it, they couldn't fix it. Now we're in this window, now they're having DCI, now we need to drive up the pressure, but like we can't go by the standard goals, and that's kind of where we get stuck in the middle with these like goals to just treat what's happening at the moment.
So in order to talk about the permissive hypertension, what that means to the bedside nurse, we have an example here. So go ahead and read the scenario, guys. So patient's intubated, sedated on propofol and fentanyl. They're requiring a little bit of levo, 5 to 8, to maintain a CPP of 90. All of a sudden now your MAP is steadily increasing to 127. So
What do you do?
what are you going to do?
Yay! Go down on your levo. That's perfect.
Check your
Okay.
patient.
However, while you're going down on your levo, right? No, but I'm being very serious. Like your pump's right next to your patient, right? So obviously you want to go down on your levo a little bit. But while you're doing that, make sure the reason that you had a blood pressure change is not just because you are on levofed, but you always, always, always check your patient. And then we're going to check a lot of things on our patient. So you got your hand on your pump, which is usually located right next to your A-line. Is your A-line level? Are you making this change based on good information? Is your waveform correct? And are you level? Please, 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 always when you're titrating, make sure that you're reading the right information. Don't just go off the number. Make sure your waveform's right. Make sure that you're level. A neuro exam, if your patient hasn't been having problems with their blood pressure, again, go back to checking your patient. You looked at them, you're checking your pupils, you're making sure everything's level, and you're going to go down on your levofed.
Yay, decrease levo.
Perfect.
What's another thing you might want to do? Why would you increase your propofol or your fentanyl?
Right, so you check your patient and they're maybe a little bit too awake, or maybe they're having pain. You know, it's all a balance. We don't want to ever have them on too much, but we also don't ever want to have them on too little.
Okay. Temperature. Check your patient's temperature. Sometimes the fever can cause things like that to happen. But the takeaway is we were trying to trick you with our PRNs, but you weren't tricked. All right. Basically, sometimes we've had this happen where people forget their patients on Levophed and they go get labetalol. Right? So it's that think about it. Okay. We have another example.
We're almost done. Just like 2 more things.
So here's a patient, they're ANO times 2, they have an EVD. You have a CPP of 120. Well, this particular patient is requiring cardine, which is not actually usually common, but they're on cardine. The last 2 hours, your CPP has now been 127. So you're above goal. You're on maxed out on your cardine. Here's your PRNs. What are you going to do? It's simple, guys. It's not a trick question.
Anyone, what do? Treat it with what? So if you're 120 and you're only over by 7 points, do you think you should automatically give a PRN? It's a hard spot. It's a really hard spot. So check your patient. Who said it? I heard it somewhere. I'm going to give you a candy. So check your patient. A lot of times, also go back through the same things we talked about. Do you have a good waveform? Are you level? Blah, blah, blah. All of those things. Do a neuroexam. But you don't want to risk the big fluctuations in blood pressure because that can also cause DCI. So this is a hard spot that we find ourselves in on an hourly basis on our unit. So should we treat that number? If you're not sure, call MCCS. And then you can just put in a provider notification for yourself if they say let it ride. Because if you don't know this, sometimes you're day free with someone and you know them and they, labetalol is like eating Skittles to them or whatever. But if you're not to that point with the patient and MCCS, do not just emergently treat this number. Call MCCS first. I'm over my goal. I've checked my patient. I've done all these things. Do you want me to treat this? Because them dropping down the other way would actually be worse for them than leaving it high. Does that make sense to everyone? Okay.
So the takeaway really is if you have a patient in the DCI window, cardine or not, let's say their blood pressure, say they're nothing. Let's say they're just 127 and they're not on a drip. I would call MCCS and before I would give a hypertensive because I would let it ride until they told me to give them. Because if we drop, you don't know what the response is going to be. They've never had labetalol. What if they go down to 80 and now you cause a stroke because you have hypoperfused them? So I would call and say, hey, are you okay with this? The blood pressure, the goal has been 127 for a couple hours now. It's a little on the higher end. Do you want me to give a PRN? They'll be like, well, what's the systolic? You're like, 180. They'll be like, no, I swear to God, that's what they'll do every time. So you need to think about it.
Make sure you write a provider notification.
Correct.
Okay? But again, we're talking about nursing care and nursing vigilance and our own what we do day to day. So if you decide not to treat this, which everyone's most likely going to agree with, you still need to cover it because it's outside your goal and you're charting it like everything's fine. So you got to write that provider notification.
My point is just be cautious. Anybody that is in the DCI window, you're about to give Nematap, you're going to give them some fentanyl. They don't need hydralazine. Does that make sense? Okay. And then I think other things that we talk about, permissive hypertension, and again, do you like my house? Euvolemia. So volume status. So typically when we do see someone in DCI or we're seeing vasospasm, they order you a bolus. But one of the things I want to remind you is people who are in this window, their eyes and nose are very important. You may have heard this. It's very hard to keep track of someone who's drinking, how much they're drinking. But if they're in this window, sometimes we put in a Foley just so that we can have the urine output. And some of you may have experienced this. But it's basically volume status. Because a hose that is collapsed, just like a garden hose, needs volume and pressure. And so frequent boluses. And the other thing to also remember, oftentimes they have new bed rest orders. So this patient yesterday was getting up to go to the bathroom, and now they're complaining to you that they have to use the bedpan, But if they get up, they could have a stroke. So sometimes bed rest is actually appropriate. I just want to remind you that these are kind of nursing driven. There's so much to vasospasm and DCI. We could not cover it all today. But these are kind of the good takeaways: permissive hypertension, and being cautious about treating with a hypertensive medicine, antihypertensive medicine. So, yay! I'm so proud of us, guys. So does anybody have any questions? Thanks, baby.
All your pictures.
I'm like a 4-year-old, like, yeah, oh, okay.
Like you guys included a lot of like the nursing-driven questions into the beta walls and CCP map. All those can be really important because that's a lot of the times when we spend time sitting about the kids and maybe not. Like you're not alone in it. You know, there's reasons as to why we let some ride high and some die and why we let some.
I'm going to give everyone a hint. Another good tool that we have on the unit is this subarachnoid hemorrhage map. And at first looks confusing, but it's really awesome tool that you can utilize. So if anyone wants one, we made a bunch of copies if you want to leave with one that can help you just reorient your brain if you need it, because there are, again, so many other things that play into this that we just didn't have time to talk about.
Thanks, guys.
Thank you guys so